इन लोग को पता है कि अभी मैं आऊंगी होस्ट डिसेबल्ड पार्टिसिपेंट स्क्रीन। इट्स डन। Okay, good morning, everyone. So, back with you people for the class. Okay, good morning, everyone. Now, I hope I'm audible and visible. Yes. So, let's continue with our gynae class, where we are going to talk more about the important points which you have to revise before you appear for this NORCET exam, right? Now, folic acid supplementation in pregnancy. Now, question number 1 related to folic acid supplementation. Folic acid supplementation, bacha, is extremely important for your exams. So the question is, what will be prescribed to the mother to prevent neural tube defect in the fetus? So all of you know that to prevent neural tube defect, we have to advise folic acid to the mother, right? Now, the questions which are asked on folic acid, there are extremely important, and many questions are asked from this topic. So over here, the next question which was asked in your NORCET exam was, use of folic acid to prevent congenital malformation should best be initiated by. So folic acid, when should it be initiated? It should be initiated before conception. All of us know that it should be initiated before conception. Now, when we talk about the dose of folic acid for all pregnant females, it is 400 micrograms. And the female should start, the pregnant female, or the female who's planning pregnancy, उनको advise करते हैं that they have to start folic acid at least 1 month before conception. Ideally, they should be beginning before conception. And अगर उन्होंने before conception start नहीं किया, then they have to begin as soon as pregnancy is diagnosed. But ideally, folic acid should be started before conception, right? And when should it be stopped? It should be stopped 3 months after conception. Now, to all pregnant females, जो हम dose देते हैं folic acid की, how much dose are we giving? We are giving 400 micrograms. And this 400 micrograms is called as prophylactic dose, right? And this dose is given to prevent neural tube defects, right? Now, in females who have previous history of babies with neural tube defect, the dose of folic acid which you have to give is 4 milligrams. The dose which you have to give is 4 milligrams. So if your patient has history of previous neural tube defect in the baby, then the dose is 4 milligrams. This should be started 3 months before conception, and it should be stopped 3 months after conception. This is called as the therapeutic dose of folic acid, and the therapeutic dose of folic acid is 4 milligrams, right? And this dose can prevent the recurrence of neural tube defect. तो जब भी क्वेश्चन देखोगे, क्वेश्चन में ध्यान रखना कि इट इज फॉर प्रिवेंशन ऑफ न्यूरल ट्यूब डिफेक्ट या फॉर रिकरेंस ऑफ न्यूरल ट्यूब डिफेक्ट. प्रिवेंशन ऑफ न्यूरल ट्यूब डिफेक्ट के लिए 400 माइक्रोग्राम्स एंड रिकरेंस ऑफ न्यूरल ट्यूब डिफेक्ट के लिए 4 मिलीग्राम्स. राइट नाउ, once 3 months are over, देखो फर्स्ट 3 months तक व्हेन अ पेशेंट बिकम्स प्रेग्नेंट हम उसको केवल फॉलिक एसिड देते हैं. एक बार जब 3 months ओवर हो जाते हैं, देन फ्रॉम 4th month onwards you have to give them iron and folic acid tablet. ये जो iron and folic acid tablet आप देते हो, this is to prevent anemia. Are you understanding? So जब भी आप folic acid को before pregnancy start कर रहे हो and you are giving folic acid up till first 3 months of pregnancy. So that is the time जिसमें जब आप folic acid देते हो, the role of folic acid is to prevent neural tube defect. जब आप आयरन के साथ folic acid देते हो from 4th month, then don't say कि अब हम जो folic acid दे रहे हैं, this is to prevent neural tube defect. ये जो 4th month से आप folic acid देते हो, this is to prevent anemia. Right? Then, coming to neural tube defects. Neural tube defect में very important is anencephaly. Anencephaly में defect क्या होता है? Anencephaly में defect ये होता है that the cranial vault, that is the skull of the fetus, is absent. Now, because skull of the fetus is absent, the brain tissue is exposed. Right? Not only this, in anencephaly, the adrenal glands are hypoplastic. Right? So skull of the fetus is absent, brain tissue exposed hota hai, and adrenal glands are hypoplastic. This is more common in female fetus. Now, in case of anencephaly, there is also a swallowing defect. Because swallowing defect hota hai, that is why in neural tube defects you get polyhydramnios, and polyhydramnios can lead to preterm labor. Please remember, in all neural tube defects, there is swallowing defect. Swallowing defect ki wajah se there is going to be polyhydramnios because amniotic fluid is always kept in balance. Ek taraf se fetus produces amniotic fluid and dusri taraf se it swallows amniotic fluid. My question to you is, tell me in first trimester, right? So please tell me, in first trimester, if I say, what is the main source of production of amniotic fluid? So in first trimester, what is the main source of amniotic fluid? Who is going to tell? What is the source of amniotic fluid in first trimester? It is an exudate from maternal plasma. Then between 12 to 20 weeks, it is fetal skin. And at more than equal to 20 weeks, it is fetal urine. Please remember, overall, it is fetal urine. Overall, fetal urine is the most important contributor to amniotic fluid, right? Now, in case of anencephaly, not only are you getting preterm labor, but if you remember last time wali class mein, I told you that the congenital malformation which can lead to post-term labor is anencephaly. So anencephaly mein, you can also get post-term labor. Now tell me, what is the investigation of choice to diagnose anencephaly? To diagnose any kind of structural defect, right? The investigation of choice is ultrasound. Now, please understand, ultrasound दो तरीके के होते हैं. It is level 1 ultrasound and level 2 ultrasound. Level 2 ultrasound, जिसको टीफा भी कहते हैं, this is the best ultrasound for detecting any congenital anomaly. किसी भी congenital anomaly को detect करने के लिए Best ultrasound is level 2 ultrasound, right? Level 1 ultrasound में you cannot detect many congenital anomalies. लेकिन फिर भी the congenital anomaly which can be detected on level 1 ultrasound is neural tube defect. Neural tube defects can be detected on level 1 ultrasound. Now, my next question to you is, when we are talking about this, tell me, I am telling you that level 2 ultrasound, जिसको टीफा कहते हैं, this is the best ultrasound for any congenital anomaly. अगर मुझे कोई भी congenital anomaly को detect करना है, TIFA, that is targeted imaging for fetal anomaly, इसको target scan भी कहते हैं and इसको anomaly scan भी कहते हैं. अब ये जो target scan या anomaly scan है, what is the time for doing it? This should be done between 18 to 20 weeks in all pregnant females. हर pregnant female में you have to do TIFA, target scan या anomaly scan. And ये कब करते हैं? Between 18 to 20 weeks, right? Now, in case of anencephaly, one second. In case of anencephaly can also be diagnosed on level 1 ultrasound. Now the question which they ask you is, earliest anencephaly can be diagnosed by? Earliest anencephaly can be diagnosed by 10 weeks. That is first trimester. Best it can be diagnosed by 14 weeks. Right? So earliest it can be diagnosed by 10 weeks and earliest by 10, and best diagnosis or most accurate diagnosis can be made by 14 weeks. Levels of alpha-fetoprotein are raised in neural tube defects. In all neural tube defects babies, alpha-fetoprotein levels will be high. Very, very important question. But अगर question पूछा जाएगा कि बेस्ट बायोकेमिकल मार्कर कौन सा होता है फॉर न्यूरल ट्यूब डिफेक्ट्स, whenever you get this question that what is the best biochemical marker for neural tube defects, you are not going to say alpha-fetoprotein. You are going to say it is acetylcholine esterase. Acetylcholine esterase. ठीक है? Now, in case of anencephaly, management is termination of pregnancy irrespective of the gestational age. Irrespective of gestational age, you have to terminate pregnancy because this is a non-viable condition. ये baby survive कर ही नहीं सकता है. That is why you have to terminate pregnancy. What is the most common presentation in anencephaly? Most common presentation in anencephaly is face presentation. इसका उल्टा क्वेश्चन पूछा जाए कि what is the most common congenital anomaly causing face presentation, then also your answer is anencephaly, right? A few important points related to alpha-fetoprotein. Alpha-fetoprotein में आपके एग्जाम में क्वेश्चन पूछा गया, maximum levels of alpha-fetoprotein are seen in. Maximum level of alpha-fetoprotein are seen in. Batao. So please remember, alpha-fetoprotein is produced by the fetal yolk sac. Initially, it is produced by fetal yolk sac. Later on, it is produced by fetal GIT and liver. So initially it is produced by fetal yolk sac, then it is produced by fetal GIT and liver. And then fetus के urine के through, it comes into amniotic fluid, and from amniotic fluid, it goes into maternal plasma. Now, whenever we are talking about मैक्सिमम लेवल्स ऑफ अल्फा फीटोप्रोटीन, मैक्सिमम लेवल्स ऑफ अल्फा फीटोप्रोटीन उसमें मिलेंगे जो प्रोड्यूस कर रहा है। सो मैक्सिमम लेवल हमें किस में मिलेगा? फीटस में मिलेगा, fetal serum में मिलेगा। Are you understanding? The answer to this question is option A. I can see many of you have answered it as option A या option C. ठीक है, तो it is option A. नर्सिंग लर्नर, बेटा लाइव क्लास में अगर मैं चैट बॉक्स पढ़ती रहूंगी, है ना, और मैं चैट बॉक्स पे तुम लोग की क्वेरीज आंसर करती रहूंगी, तो यू टेल मी कि पढ़ाऊंगी कब? तो इसीलिए लास्ट में आई विल गिव यू 5 minutes, जब आई विल बी लुकिंग ओनली एट द चैट बॉक्स एंड आई विल बी टेकिंग अप योर आंसर्स, आई विल बी टेकिंग अप योर क्वेरीज। ठीक है, अभी आई एम कॉन्सेंट्रेटिंग ओनली ऑन टीचिंग यू व्हाट इज इंपॉर्टेंट एंड ऑन सीइंग टू इट कि क्वेश्चंस के तुम लोग आंसर्स क्या दे रहे हो। अभी तुम्हारे क्वेश्चंस को अगर मैंने पढ़ पढ़ के आंसर करना शुरू किया तो क्लास का मोमेंटम टूट जाएगा, राइट? सो लास्ट के 10 minutes आई विल गिव, जहां पे सब लोग अपनी क्वेरीज पूछना एंड आई विल आंसर ऑल योर क्वेरीज। ठीक है, नाउ in which of the following conditions would maternal serum alpha fetoprotein levels be highest? So when will be the maternal serum alpha fetoprotein highest, in which condition? So please remember, alpha fetoprotein levels are highest in neural tube defects, followed by abdominal wall defect, right? And in abdominal wall defect, most important is gastroschisis. Both gastroschisis and omphalocele, they are causes of high alpha fetoprotein levels. इन दोनों में से अगर चूज करना होगा तो इट इज गोइंग टू बी gastroschisis. प्लीज रिमेंबर, जो तुम लोग ए मार्क कर रहे हो दैट इज रॉन्ग। देखो, अल्फा फीटोप्रोटीन बहुत सारी कंडीशंस में रेज्ड होता है, बट अल्फा फीटोप्रोटीन लो होता है इन GOAT, राइट? GOAT, जहां पे G stands for gestational trophoblastic disease, O stands for overestimated gestational age, A stands for abortion, T stands for trisomy. So जब भी ट्राइसोमी होती है, in that condition the Down syndrome is a trisomy 21. So Down syndrome में the levels of alpha fetoprotein would be decreased, right? Highest level मिलता है neural tube defect में, followed by abdominal wall defect, and abdominal wall defect में you are going to mark the answer as gastroschisis, right? Next question. In a pregnancy in which alpha fetoprotein levels are increased, what should be done? अगर आपके पास alpha fetoprotein levels high आए हैं, what should be done? Option A, repeat alpha fetoproteins at a later date. Option B, ultrasound. Option C, amniocentesis. Option D, termination of pregnancy. A, B, C, D. Tell me the answer. बताओ, A, B, C और D? A, B, C और D? कोई कह रहा है C, कोई कह रहा है B, कोई कह रहा है A। चल, अब मैं बताती हूँ। देखो, जब भी अल्फा फीटोप्रोटीन रेज होता है, हम क्या कह रहे हैं कि या तो न्यूरल ट्यूब डिफेक्ट होगा या एब्डोमिनल वॉल डिफेक्ट होगा, एंड ये दोनों के दोनों क्या है? स्ट्रक्चरल डिफेक्ट्स हैं, राइट? तो जब भी अल्फा फीटोप्रोटीन लेवल्स रेज्ड होंगे, हमारा अगला स्टेप क्या होगा? अल्ट्रासाउंड। अब इसमें ना आई वांट टू क्लियर योर वन कॉन्सेप्ट, ओल्डर टाइम्स में एंड अब रिसेंट में डिफरेंस है। अर्लियर जब हमारे पास अल्ट्रासाउंड अवेलेबल नहीं था, तब हम क्या करते थे, अगर अल्फा फीटोप्रोटीन रेज होता था तो हम करते थे एमनियोसेंटेसिस, राइट। एमनियोसेंटेसिस एक इन्वेजिव प्रोसीजर है। अब जब हमारे पास अल्ट्रासाउंड अवेलेबल है, तो अब जब हमारे पास अल्फा फीटोप्रोटीन रेज्ड होगा तो हम क्या करेंगे, तो अब हम करेंगे अल्ट्रासाउंड, राइट। Why? Because we are suspecting structural defects. And structural defects के लिए always and always you should be going for ultrasound. ठीक है? Okay. As I told you, alpha fetoprotein levels किस में raised होते हैं? Neural tube defect में, abdominal wall defects में, pilonidal sinus and sacrococcygeal teratoma. ये list बहुत लंबी है. I want you to remember कि alpha fetoprotein levels decreased किस में होते हैं? Alpha fetoprotein levels decreased होते हैं GO80, right? Okay. Then next very important topic जिस पे बहुत questions आते हैं, that is related to anemia मुक्त भारत program. Anemia मुक्त भारत program में many questions are asked in your exam. So number one question is, iron and folic acid dose in a pregnant female is. Iron and folic acid dose in a pregnant female is. So what is the iron and folic acid dose in a pregnant female according to Anemia Mukt Bharat program? A, B, C and D. Yes, very good. Sheetal, Kiran, Poonam, excellent. The answer is option A, right? So over here, it is 60 milligram plus 0.4 milligrams of folic acid, 60 milligrams of iron and 400 micrograms of folic acid. Now understand, अनीमिया मुक्त भारत प्रोग्राम का एम क्या है? अनीमिया मुक्त भारत प्रोग्राम का एम है टू प्रिवेंट अनीमिया एंड नॉट टू ट्रीट इट. अनीमिया मुक्त भारत प्रोग्राम में there are 6 interventions which are included, and this you have been taught in your community nursing class also, and I have also taught you what are the 6 interventions which are included in Anemia Mukt Bharat program. Number 1, you have to use a digital thermometer. Number 2, iron folic acid pills. Number 3, deworming. So number 3 is deworming. Number 4, food fortification. Number 5, delayed cord clamping. Why is delayed cord clamping included? Because it can prevent neonatal anemia. It is a method of preventing neonatal anemia. अच्छा, second वाले question में you are right. 60 milligrams of iron दिया है, साथ में 500 micrograms folic acid दिया है. So our answer has to be 60 milligrams and 500 micrograms of folic acid. Thank you for pointing out, बेटा. Right? इसीलिए questions के options नीचे तक पढ़ने जरूरी है. First option पढ़ के answer नहीं देना चाहिए. True. Thank you so much. Now, please remember, according to Anemia Mukt Bharat program, जितनी भी reproductive age females होती हैं, उनको हम IFA pill देते हैं weekly. IFA pill का composition क्या होता है? IFA pill का composition होता है 60 milligrams of iron and 500 micrograms of folic acid. क्या कलर होता है IFA pill का? रेड कलर की पिल होती है, राइट? एंड जितनी भी रिप्रोडक्टिव एज फीमेल्स हैं, उनमें हमें डीवॉर्मिंग करनी होती है विथ 400 मिलीग्राम्स ऑफ एल्बेंडाजोल, एंड इसको हम करते हैं ट्वाइस अ ईयर. ट्वाइस अ ईयर हमें उसमें डीवर्मिंग करनी, राइट? ट्वाइस अ ईयर. ना, जब ये फीमेल प्रेगनेंसी के लिए प्लान करती है, आई हैव टू स्टॉप गिविंग हर iron folic acid pill and I have to now give her only folic acid pill. कितना देना है folic acid? 400 micrograms per day. And कब तक देना है? Till 3 months after conception. Now, at 4th month of pregnancy, I have to stop folic acid and again I have to start 1 IFA tablet per day. This IFA tablet should be continued throughout pregnancy plus for 180 days after delivery. So throughout pregnancy continue karni hai and I have to give it for 180 days after delivery. Please remember कि pregnant females में भी deworming के लिए you have to give albendazole, which should be given in 2nd trimester. Now, when we are saying that we are giving for 180 days after delivery, why are we giving for 180 days after delivery? To replenish the iron stores. समझ में आया? So ताकि iron stores replenish हो सके, दोबारा से भरे जा सके, that is why we are giving for 180 days after delivery. ठीक? Now, remember to prevent anemia. जब भी आपने अनीमिया को प्रिवेंट करना है, IFA pill should be started from 4th month of pregnancy. But अगर आपको अनीमिया को ट्रीट करना है, in that case you have to start IFA pill from the time when anemia is detected. अभी थोड़ी देर पहले someone in chat box was writing कि मैम अगर किसी प्रेग्नेंट फीमेल को 1st ट्राइमेस्टर में अनीमिया हुआ, सो रिमेंबर जब भी किसी प्रेग्नेंट फीमेल को अनीमिया होता है, राइट, जब भी किसी प्रेग्नेंट फीमेल को अनीमिया होगा, आई हैव टू सी कि उसको 1st ट्राइमेस्टर में हुआ है या उसको 2nd and 3rd ट्राइमेस्टर में हुआ है. अगर अनीमिया 1st ट्राइमेस्टर में हुआ है, in 1st trimester I have only 2 options. कौन से 2 ऑप्शन होते हैं हमारे पास? Only I have oral iron and blood transfusion. These are the only 2 options to treat anemia in 1st trimester. Please remember parenteral iron. Parenteral iron is contraindicated in 1st trimester, right? So 1st trimester में whenever there is anemia in 1st trimester, कैसे ट्रीट करोगे? 1st trimester में अगर अनीमिया है तो पहले तो मुझे ये बताओ कि अनीमिया की डेफिनेशन क्या होती है? हाउ डू यू डिफाइन अनीमिया? अनीमिया की डेफिनेशन क्या होती है इन प्रेगनेंसी? In pregnancy, if hemoglobin is less than 11 grams per dl, that is anemia, right? What is severe anemia? Severe anemia is hemoglobin less than 7 grams, right? And what is very severe anemia, beta? Very severe anemia is hemoglobin less than 4 grams, right? Now, 1st trimester में जब भी अनीमिया होगा, I am going to see कि hemoglobin of the patient क्या है. अगर hemoglobin of the patient, if hemoglobin of the patient is less than 5 grams, or if your patient has signs of heart failure, if hemoglobin is less than 5, or if there are signs of heart failure, then the only option is blood transfusion. If hemoglobin of your patient is more than 5 and there are no signs of heart failure, then in that case, I have to give oral iron. Now, whenever you are giving oral iron to treat anemia, right, then the dose of iron is 2 IFA pills per day. To treat anemia, 2 IFA pills per day have to be given. So again, I am reminding you the same thing. Anemia ko agar prevent karna hai, right, then in that case, I have to start IFA pill from 4th month of pregnancy. लेकिन अगर anemia को treat करना है, then in that case, IFA pills have to be started from the day the diagnosis is made. अगर anemia को prevent करना है, then the dose of IFA pill is 1 pill per day. और अगर अनीमिया को ट्रीट करना है, then the dose is 2 pills per day. ठीक है? Please remember, IFA pills का composition is 60 milligrams of iron, 500 micrograms of folic acid, and color of IFA pill is red colored. ठीक है? Now suppose I ask you that there is a pregnant female who comes to you with anemia in second या third trimester. अगर एक प्रेग्नेंट फीमेल आपके पास अनीमिया सेकेंड या थर्ड ट्राइमेस्टर में लेकर आती है, इन दैट केस यू हैव टू सी कि हीमोग्लोबिन पेशेंट का क्या है. हीमोग्लोबिन मोर देन 7 है या हीमोग्लोबिन लेस देन 7 है. राइट? हीमोग्लोबिन लेस देन 7 को हम फर्दर डिवाइड करते हैं हीमोग्लोबिन लेस देन 5 and hemoglobin between 5 to 7. Right? So hemoglobin less than 5 and hemoglobin between 5 to 7. ठीक? Now, understand, जब भी hemoglobin less than 5 होता है, always the management is blood transfusion. And hemoglobin जब between 5 to 7 आ जाएगा, in that case patient की gestational age को देखो. क्वेश्चन में देखो कि कितने वीक्स प्रेग्नेंट है फीमेल. अगर फीमेल्स मोर देन इक्वल टू 34 वीक्स प्रेग्नेंट है, तब तो ब्लड ट्रांसफ्यूजन दो. लेस देन 34 वीक्स प्रेग्नेंट है तो पैरेंट्रल आयरन. लेस देन 34 वीक्स पे हम पैरेंट्रल आयरन इसलिए देते हैं, मोर देन 34 वीक्स पे पैरेंट्रल आयरन इसलिए नहीं दे पाते बिकॉज पैरेंट्रल आयरन में जो रेट ऑफ इंक्रीज ऑफ हीमोग्लोबिन होता है, दैट इज सीन आफ्टर 3 वीक्स. तो इसीलिए अगर पेशेंट 34 वीक से ज्यादा प्रेग्नेंट है, in that case I am not preferring parenteral iron अगर उसका हीमोग्लोबिन less than 7 है. Imagine अगर पेशेंट मेरे पास 35 वीक्स पे आई है एंड वो हीमोग्लोबिन 6 लेकर आई है. अब अगर वो हीमोग्लोबिन 6 लेकर आई है और 3 वीक्स के बाद जाके हीमोग्लोबिन बढ़ेगा, और कितना बढ़ेगा? 0.7 grams to 1 gram per DL per week. तो अगर मेरे पास पेशेंट 36 वीक्स पे आई है 6 ग्राम्स हीमोग्लोबिन लेके, ना 3 वीक्स के बाद उसका हीमोग्लोबिन बढ़ेगा 39 वीक्स पे एंड कितना हो जाएगा? 6.7 या 7. क्या बहुत अच्छा हो गया? नहीं. राइट? तो अभी भी पेशेंट अनीमिक ही है और अभी भी अगर मैं डिलीवरी कराऊंगी सारे के सारे रिस्क होंगे. That is why जब भी gestational age more than equal to 34 weeks होती है, in that case it is better that we go for blood transfusion. Blood transfusion में within 24 hours hemoglobin increases. Right? Now, if hemoglobin is more than 7, if hemoglobin is more than 7, again look at the gestational age. अगर gestational age less than 34 weeks है, go for oral iron. And more than equal to 34 weeks है, parenteral iron. Please remember, rate of increase of hemoglobin. Rate of increase of hemoglobin, which I told you for parenteral iron. Parenteral iron, I told you that the rate of increase of hemoglobin is seen after 3 weeks, and it is 0.7 to 1 gram per DL per week. Right? So rate of increase of hemoglobin in parenteral iron is same as oral iron. दोनों में हीमोग्लोबिन 3 वीक्स के बाद बढ़ता है एंड दोनों में हीमोग्लोबिन 0.7 to 1 ग्राम पर DL पर वीक बढ़ता है, राइट? प्लीज अंडरस्टैंड, जब भी आप ओरल आयरन दे रहे हो ट्रीटमेंट के लिए, हमेशा यू हैव टू गिव 2 IFA pills per day. 2 IFA pills per day. Right? Clear to all of you? तो एडवांटेज क्या होता है पैरेंटल आयरन का? पैरेंटल आयरन का एक ही एडवांटेज होता है कि वो पेशेंट पे डिपेंडेंट नहीं होता, राइट? हम देते हैं पैरेंटल आयरन, वी आर नॉट डिपेंडेंट ऑन द पेशेंट. नेक्स्ट क्वेश्चन, what is the most common anemia in pregnancy? Most common anemia in pregnancy is physiological anemia. Next question, what is the most common pathological anemia in pregnancy? Most common pathological cause of anemia in pregnancy is iron deficiency anemia. In iron deficiency anemia, which is the earliest marker of iron deficiency anemia? The earliest marker of iron deficiency anemia is decreased serum ferritin levels. That's the earliest marker of iron deficiency anemia. Next important point, which RBC index is most sensitive for iron deficiency anemia? Yes, so which RBC index is most sensitive for iron deficiency anemia? The RBC index which is most sensitive for iron deficiency anemia is MCHC, right? Next question. What is the total iron requirement in pregnancy? Total iron requirement in pregnancy is 1000 milligrams. How much iron is needed by fetus in pregnancy? How much iron is needed by the fetus in pregnancy? 300 milligrams. 300 milligrams. Next question. After giving iron, when you are giving iron, whether in the form of oral iron or parenteral iron, the parameter which increases first, which is the first parameter to increase after giving oral or parenteral iron? Which is the first parameter? Batao, which is the first parameter to increase? It's not hemoglobin. Hemoglobin to 3 weeks ke baad badhta hai. Which is the first parameter? Excellent, Jitendra. And Prayur. Sorry, I'm pronouncing your name incorrectly. It is reticulocyte count. Reticulocyte count. Okay? So these are some of the important questions related to anemia in pregnancy. Anemia in pregnancy is an extremely important topic. Now, coming to important questions on maternal adaptation in pregnancy. So first question is, pinkish white lines which are found in the lower abdomen during pregnancy, what are they called as? So please remember, during pregnancy, there is a brown colored line which you can see running from the umbilicus to the pubic symphysis. This brown colored line is called as linea nigra, right? Then you have pink colored stretch marks. Now, if pink colored stretch marks are present, they represent stretch marks of present pregnancy, and they are called as stria gravidarum, right? Stria gravidarum. Now, stretch marks of previous pregnancy are silvery white in color, and they are called as stria albicans. Previous pregnancy, they are silvery white and they are called as stria albicans. What is pregnancy mask or chloasma gravidarum? You all have seen dark colored skin can happen on the cheek, right, on the forehead. That is in Hindi, which is called as jhaiya, right? That is what is chloasma gravidarum or pregnancy mask. They are seen on cheek and they are seen on forehead, right? Coming to signs in early pregnancy. Now, signs in early pregnancy okay. In maternal adaptation in pregnancy, I also want you to tell me what are the hematological changes which occur in pregnancy. What are the hematological changes, important hematological changes which happen during pregnancy? So important hematological changes which happen during pregnancy, you can make a table. There are certain parameters which are going to increase and there are certain parameters which are going to decrease, right? In increased parameter, we have blood volume. Blood volume increases in pregnancy. When I say blood volume increases, plasma volume also increases, RBC volume also increases. Increase in plasma volume is 40 to 50%. Increase in RBC volume is 20 to 30%. Right? Because liquid component is increasing more than solid component. That is why there is hemodilution in pregnancy. Because liquid component is increasing more than solid component. So during pregnancy, there is hemodilution. This hemodilution ki wajah se the viscosity of blood, the thickness of blood will decrease. Right? Now, what happens to packed cell volume? Packed cell volume. What happens to packed cell volume in pregnancy? Packed cell volume is RBC volume divided by plasma volume. Now, in pregnancy, both of them are increasing, but the increase in denominator is more than the increase in numerator. That is why packed cell volume decreases in pregnancy. Another name for packed cell volume is hematocrit. So what happens to hematocrit in pregnancy? Hematocrit in pregnancy is going to decrease. Next important point, what happens to the hemoglobin mass? That is the total amount of hemoglobin. Total amount of hemoglobin is measured in grams. So what happens to hemoglobin mass in pregnancy? Hemoglobin mass in pregnancy will increase. But when we are talking about hemoglobin concentration, that is grams per deciliter, then it is going to decrease. Because hemoglobin mass is increasing, so the amount of oxygen, the oxygen carrying capacity is also going to increase. Oxygen carrying capacity increases. Please remember, this decrease in hemoglobin during pregnancy, this is called as physiological anemia. So, हर pregnant female में hemoglobin decreases in pregnancy. But how do we differentiate between physiological anemia and pathological anemia? In physiological anemia, hemoglobin will always remain more than 11. For example, if there are two pregnant females, Mrs. A and Mrs. B, Mrs. A and B का hemoglobin before pregnancy was 12.6, दोनों का. During pregnancy, Mrs. A का हो जाता है 11.6. So 12.6 से decrease हुआ, हो गया 11.6. And Mrs. B का हो जाता है 10.6. तो इसमें से Mrs. A का hemoglobin क्योंकि 11 से ऊपर रहा, I am going to call it as physiological anemia. and क्योंकि Mrs. B का hemoglobin less than 11 हो गया, I will say that she has pathological anemia, right? Okay. Then what happens to WBC count in pregnancy? WBC count increases in pregnancy. Platelet count decreases in pregnancy, and this decrease is called as benign gestational thrombocytopenia. Benign gestational thrombocytopenia. Right? Next important point. What happens to all inflammatory markers? All inflammatory markers, whether it is C-reactive protein, whether it is ESR, all of them, it is going to be increased, right? Next important point, what happens to plasma protein mass? Mass of plasma protein, which is measured in grams, is going to increase. But when we talk about plasma protein concentration, which is measured in grams per deciliter, it is going to decrease. Please remember, globulins increase during pregnancy and albumin decreases during pregnancy. ये question ऐसे नहीं आता. They are going to ask you what happens to sex hormone binding globulin, what happens to thyroid binding globulin. So all globulins increase in pregnancy. Please remember, normally albumin is to globulin ratio is 1.7:1. In pregnancy, this becomes 1:1. All clotting factors increase in pregnancy. That means pregnancy is a hypercoagulable state. So all clotting factors increase in pregnancy except for factor number 11 and 13. Factor 11 and 13 decrease during pregnancy. What are the parameters which remain constant? The parameters which are going to remain constant in pregnancy are bleeding time, clotting time. Bleeding time and clotting time are the ones which remain constant during pregnancy. Clear to all of you? So these are the hematological changes which occur in pregnancy, which are extremely important for all of you. Clear? BTCT is bleeding time, clotting time. Now, just 2 minutes though, I'm just coming. Just give me 2 minutes. I want to have water, right? Because continuously, oh, sorry, one second. Continuously, I've been taking a class, right? So just give me water. First, I was in Mumbai. Now I'm in Hyderabad for a class. So just give me 2 minutes. I'll have water and I'll come. Yeah. Okay. So, coming to, I'm back. You want NST and CTG. Okay, I'll be taking up NST and CTG also. Okay. Important points on family planning. Family planning तुम लोग का मुकमोहित सर ने लिया होगा ना बेटा? Has Mukmohit sir taken family planning for you people? Okay, chalo. Coming to signs in early pregnancy. Signs in early pregnancy में बहुत सारे questions पूछे जाते हैं. So number one is bluish discoloration of vagina and cervix in first trimester is called as. All of you know क्या कहते हैं bluish discoloration of vagina and cervix को? Pramendra Chaudhary, I will answer your question, beta. Abhi I'll answer your question. So bluish discoloration, what is it called as? It is called as Chadwick sign या Jackmere sign. Please remember the earliest sign in pregnancy is Goodell sign. That is softening of the cervix, which happens at 6 weeks of pregnancy. Then we have the Hagar sign. Hagar sign becomes positive between 6 to 10 weeks of pregnancy. Hagar sign में क्या करते हो? आप bimanual palpate करते हो. Hagar sign is based on the principle कि जितना भी product of conception होता है in first trimester वो upper part of the uterus में होता है, lower part of the uterus empty होता है, and जब आप palpate करोगे with both your hands, one hand in vagina, other hand per abdominally, तो क्या होगा? Then in that case, both the hand fingers are going to approximate each other or touch each other because lower part empty hai and lower part soft hai. That is what is your Hagar sign. Then we have Piscasic sign. Piscasic sign is unequal growth of the uterus in early pregnancy. Osiander sign, matlab pulsations are felt in the lateral fornix of vagina. Palmer's sign, they are irregular contractions which are felt in the uterus in first trimester. Now, चाहे वो Piscasic हो, चाहे वो Osiander हो, चाहे वो Palmer हो, चाहे वो Chadwick हो, all these signs become positive at 8 weeks. Goodell sign positive हुआ था at 6 weeks. And Hagar sign positive हुआ था between 6 to 10 weeks. Right? Now comes second trimester. Second trimester में, before we go to the second trimester, you should know what is the height of the uterus at some important levels. So, सबसे पहले बताओ, what is the height of the uterus at 12 weeks of pregnancy? At 12 weeks of pregnancy, uterus is palpable just at the level of pubic symphysis, right? Then they ask you, when is the height of the uterus at the level of umbilicus? Please remember, height of the uterus just below the level of umbilicus is 20 weeks. Height of the uterus at upper border of umbilicus is 24 weeks. अगर वो at umbilicus पूछे तो 22 weeks. What is the height of the uterus? When is the height of the uterus corresponding to Ziffy sternum? So height of the uterus corresponds to Ziffy sternum at 36 weeks. At 36 weeks of pregnancy, height of the uterus is going to correspond to Ziffy sternum. Clear to all of you? Yes? Right? So these are some important landmarks which you have to remember. Please remember, in second trimester, uterus is going to become an abdominal organ. And a very important thing which is going to happen in second trimester is fetal movements will be felt by the mother. This feeling of fetal movement by the mother, that is what is called as quickening. Quickening is felt in primigravida female at 18 weeks and in multigravida female at 16 weeks, right? So, Ayushi क्या पूछा बेटा? 24 or 22? अच्छा, understand. Lower border of umbilicus पे 20 weeks. अपर बॉर्डर ऑफ अम्बिलिकस पे 24 वीक्स, एट द लेवल ऑफ अम्बिलिकस 22 वीक्स. क्लियर? अच्छा, रिम्पा इज सेइंग कि मैम अगर 22 is not given, then among 20 and 24, which should be marked at the level of umbilicus? So at the level of umbilicus, you should mark 20 weeks. 20 weeks just at the level of umbilicus. Ideally 22 होता है, right? Ideal answer is 22. But अगर 20 and 24 में से एक mark करना हो, then mark it as 20 weeks. ठीक है? What is the height of the uterus? Next important question. What is the height of the uterus just after delivery? What is the height of the uterus just after delivery? Batao. What is the height of the uterus just after delivery? It is just below the umbilicus. Just below the umbilicus, that is at 20 weeks. Just below the umbilicus at 20 weeks. Right? After this, how is the height of the uterus going to change after delivery? So till 24 hours, till 24 hours after delivery, it is unchanged. Till 24 hours after delivery, it is unchanged. Then it decreases by 1 finger breadth per day. 1 finger breadth per day. So please understand that height of the uterus immediately after delivery is just below the umbilicus, and that is 20 weeks, right? Till 24 hours after delivery, it remains unchanged. And then it is going to change by 1 finger breadth per day. Clear to all of you? Yes? Okay. Then, in third trimester, in late third trimester, a very, very important sign which we get is welcome sign or lightening. What is welcome sign or lightening? Please see over here. At 36 weeks, height of the uterus is at the level of 𝑥 तो जब height of the uterus at the level of 𝑥 होती है, at that time mother is having a lot of respiratory discomfort. After 36 weeks, what is going to happen? Head of the fetus is going to go down into the pelvis. When head of the fetus is going to go down into the pelvis, the height of the uterus will decrease. And height of the uterus at 40 weeks is same as the height of the uterus at 32 weeks of pregnancy. So, जो mother को extremes में respiratory difficulty हो रही थी, because height of the uterus was at the level of 𝑥. जैसे ही height of the uterus decrease होगी, mother will be relieved of her respiratory discomfort, and that is what is called as lightening or welcome sign. Lightening or welcome sign is seen in late third trimester. At what time? After 36 weeks of pregnancy. Right? And why is it happening? It is happening because head of the fetus goes down into the pelvic cavity. Clear to all of you? Right. Now, what are the presumptive signs of pregnancy? Presumptive signs of pregnancy, they are those signs which are felt by the patient. They are not felt by the examiner. Right? Then we have probable signs. Probable signs are those signs which can be felt by the examiner. And then there are definitive signs. Definitive signs भी examiner feel करता है. Probable signs में 100% diagnostic criteria नहीं है pregnancy का. लेकिन definitive signs अगर आपको मिल रहे हैं, that is 100% confirmed pregnancy. So there are 3 types of signs. Presumptive signs, probable signs, definitive signs. Presumptive signs are felt by the patient and not the doctor. Probable signs and definitive signs are felt by the doctor. Difference क्या है? Probable signs से हम 100% diagnosis नहीं बना सकते pregnancy की. Definitive signs से हम 100% diagnosis बना सकते हैं. Now presumptive signs में ना सारे symptoms include होते हैं, and कैसे याद रखोगे? Presume. Presumptive से presume. So period absence, that is amenorrhea, is a presumptive sign. If the mother is really tired, that means she's having fatigue. That is a presumptive sign. Enlarged breasts are presumptive sign. Sore breast are presumptive signs. Then increased urinary frequency is a presumptive sign. Fetal movement. Yahan pe I'm talking about quickening, right? Quickening is felt by the patient. So quickening is a presumptive sign, and emesis, that is vomiting, is a presumptive sign, right? Now, probable signs of pregnancy में आएगा Osiander sign, Goodell sign, Piscasic sign, Hagar sign, Palmer sign, Braxton Hicks contractions. Skin में जो changes देखे जा रहे हैं, ballotment, all this is going to come under probable signs of pregnancy. And in definitive signs of pregnancy में number 1, if you are getting evidence of pregnancy on ultrasound, अगर अल्ट्रासाउंड में आपको एविडेंस दिख रहा है प्रेगनेंसी का, कार्डियक एक्टिविटी, जेस्टेशनल एज, जेस्टेशनल सैक, फीटल पोल, कुछ भी दिख रहा है, then that is a definitive sign. अगर fetal heart sounds are heard, if fetal heart sounds can be heard by Doppler or by stethoscope, that is a definitive sign. If fetal parts are felt per abdominally by me, or fetal movement is felt by me as an examiner, then that becomes a definitive sign. Fetal movement felt by the mother, that is quickening, is a presumptive sign. Fetal movement felt by the examiner is a definitive sign. And if on chest, if on X-ray, you can get to see the fetal skeleton. Please understand, I am not going to do X-ray during pregnancy. But by chance, अगर X-ray किया and अगर मुझे skeleton दिख रहा है fetus का, then that is a definitive sign, right? Now, someone was asking me कि अगर UPT positive है तो वो कौन सा sign होगा? UPT positive है तो वो probable sign होगा pregnancy का, right? अब ये जितने भी definitive signs होते हैं, ये absent होते हैं in pseudocysis, that is false pregnancy. If a female is faking her pregnancy, in that case, none of these definitive signs will be positive. You are never going to get any evidence of pregnancy on ultrasound. Fetal heart sounds will not be heard. Fetal parts will not be palpable, and you will not be able to see a fetal skeleton, right? Now, as I told you, X-ray is contraindicated in pregnancy. Remember, they can ask you, what is the maximum permissible radiation in pregnancy? Maximum permissible radiation in pregnancy which you can allow is 5 rads. But suppose एक patient है जिसका accident हुआ, patient unconscious state में है, and आपने उसका X-ray करा, and patient pregnant निकली. आपने एक X-ray कर लिया. Now, should I advise the patient to undergo MTP? No. अगर 1 या 2 X-rays in pregnancy हो भी जाते हैं due to emergency reasons, then also the radiation exposure is much less than 5 rads. And that is why we are not going to tell her to do an MTP. Clear to all of you? My next question to you is that tell me, what are the investigations which are absolutely contraindicated in pregnancy? The investigations which are absolutely contraindicated in pregnancy are any investigation where you are using a contrast. Then gadolinium MRI, right? Then radioactive iodine, right? Then X-ray is contraindicated but not absolutely. In emergency conditions, you can do it. Ideally, it is contraindicated, but in emergency conditions, you can do it. Similarly, CT scan, ideally, it is contraindicated, but in emergency situations, I can do it. Then, investigations which are absolutely contraindicated may, obviously, I am not going to put a hysteroscope inside the uterus during pregnancy. I am not going to put a dye inside the uterus during pregnancy, right? Then, in investigations which are safe, they are ultrasound and MRI. Ultrasound and MRI are safe in pregnancy. Then there is something which is called as fetal growth period. You have to tell which fetal growth period is most teratogenic. Most teratogenic period. Option A, a fertilized ova. Option B, embryonic period. Option C, fetal period. Option D, at the time of birth. So, which is the most teratogenic growth period? Most teratogenic period is embryonic period. Please remember, growth periods, they are all calculated from the day of fertilization. They are not calculated from first day of last menstrual period. So we have embryonic period. What is embryonic period? Embryonic period is from 3 weeks after fertilization up till 8 weeks after fertilization. Right? This is the most teratogenic period. Right? Then there is something called as fetal period. Fetal period is more than equal to 9 weeks after fertilization and up till delivery. Right? So these are the fetal growth periods. Next question. Your pregnant patient, before pregnancy, she was having hypothyroidism. Right? Now, what are you going to do in pregnancy? In pregnancy, you are going to continue her thyroxine, plus you are going to increase the dose of thyroxine by 30%. You are going to increase the dose by 30%. Now, if you have a pregnant patient who before pregnancy was on warfarin, what are you going to do? If your patient before pregnancy was on warfarin, warfarin is teratogenic. Right? So I am going to change the patient to low molecular weight heparin. I am going to tell her to use low molecular weight heparin. If a pregnant patient before pregnancy was on oral hypoglycemic drugs, right? Oral hypoglycemic drug. What am I going to do? During pregnancy, I am going to change the patient to insulin. I'm going to change her to insulin, right? If my patient before pregnancy was on anti-epileptic drugs, then please remember, during pregnancy, we do not change the drug. We do not change the drug. We give the lowest possible dose. You have to give the lowest possible dose, right? Next. In case a pregnant female has hyperthyroidism? A pregnant female has hyperthyroidism. If a pregnant female has hyperthyroidism, then in first trimester, the drug of choice is propylthiouracil. In second and third trimester, the drug of choice is, tell me, what is the drug of choice in second and third trimester? Carbimazole या methimazole. ओवरऑल पूछे, कोई ट्राइमेस्टर नहीं दिया है, ओवरऑल पूछे व्हाट इज द ड्रग ऑफ चॉइस? ओवरऑल द ड्रग ऑफ चॉइस इज propylthiouracil. टेल मी, in anti-epileptic drugs, which is the most teratogenic? Which is the most teratogenic? Most teratogenic anti-epileptic drug, that is valproic acid. Which is the least teratogenic? Which is the least teratogenic? Least teratogenic is, which is the least teratogenic anti-epileptic drug? Lamotrigine and levetiracetam. Lamotrigine and levetiracetam. Suppose a pregnant female has bacterial vaginosis. What is the drug of choice? So if a pregnant female has bacterial vaginosis, drug of choice is metronidazole. If a pregnant female has trichomonas infection, what is the drug of choice? Again, the drug of choice is metronidazole. If a pregnant female has candidiasis, what is the drug of choice? Drug of choice, do not say it's fluconazole. It is topical clotrimazole. Topical clotrimazole. Right? If a pregnant female has appendicitis, what is the treatment of choice? So if your patient, it is not fluconazole, beta. It's not fluconazole. Candidiasis in pregnant female, drug of choice is not fluconazole, it's topical clotrimazole. If a pregnant female has appendicitis, what is the treatment of choice? बताओ क्या करोगे? एक प्रेग्नेंट फीमेल को अपेंडिसाइटिस हो गया, हाउ आर यू गोइंग टू मैनेज? Tell me, how will you manage it? If a pregnant female has appendicitis, how will you manage? जल्दी बताओ. Immediate appendectomy. You are going to do immediate appendectomy. Right? Now, if a pregnant female has red degeneration of fibroid, how are you going to manage her? If a pregnant female has red degeneration of fibroid, how will you manage her? You are going to go for conservative management. No myomectomy. You are not going to do myomectomy. No termination of pregnancy. Clear to all of you? Right? Okay. Now, let's talk quickly about heart disease in pregnancy. heart disease in pregnancy. So first of all, you are going to tell me what are the cardiovascular changes which occur in pregnancy. Again, the same thing. What parameters are going to increase in pregnancy? What parameters decrease in pregnancy? And what parameters remain constant? So the parameters which increase in pregnancy are cardiac output. Cardiac output is stroke volume into heart rate. All these three things increase in pregnancy. Now, in pregnancy, because progesterone is the main hormone, and progesterone is a smooth muscle relaxant. Progesterone smooth muscles को relax करता है. That is why peripheral vascular resistance decreases in pregnancy. And क्योंकि peripheral vascular resistance decrease होता है, तो BP decreases in pregnancy. BP में हमारे पास systolic BP, diastolic BP and mean BP सब कुछ decrease होगा during pregnancy, right? What remains constant? JVP remains constant. Very, very important point, right? Next important point is they can show you an image and they can ask you, for example, they can show you this image. This image over here. They can say that a female was lying supine and her BP decreased, right? What are you going to do? Please remember, whenever a female lies supine, what is going to happen? The gravid uterus is going to press on inferior vena cava, because of which the venous return is going to decrease. So cardiac output is going to decrease, and that is going to lead to hypotension in the pregnant female. This is what is called as supine hypotension syndrome. अब अगर mother का cardiac output decrease होगा, तो amount of blood which is going to the fetus will also decrease. So there can be fetal distress. That is why all pregnant females are asked to lie in left lateral position. So as a medical profession people, अगर हमें patient supine लेती है and उसको अगर dizziness हो रहा है, उसको अगर BP decrease हो रहा है, तो immediately हमें क्या करना है? We have to turn the position and make it left lateral. This is called as supine hypotension syndrome. This is because of the pressure of the pregnant uterus on inferior vena cava. Clear to all of you? Okay. Next important point. What happens to heart rate in pregnancy, BP in pregnancy, JVP in pregnancy, S1, S2, S3 in pregnancy, murmurs in pregnancy? So as I told you, heart rate increases, so pulse rate also increases in pregnancy. BP decreases in pregnancy. JVP remains normal in pregnancy. S1 is loud, plus its splitting is prominent in pregnancy. S2 is normal, and S3, which is normally not easily heard, it is easily heard in pregnancy. Right? There are two murmurs which are absolutely normal in pregnancy. Number one, ejection systolic murmur. Ejection systolic murmur is absolutely normal in pregnancy, and a continuous murmur is absolutely normal. In case of pregnancy, on ECG, you will get left axis deviation. Because डायफ्राम जब ग्रो करेगा वो यूट्रस को पुश करेगा यूट्रस को ऊपर की तरफ. जब यूट्रस ग्रो करेगा यूट्रस डायफ्राम को पुश करेगा, डायफ्राम हार्ट को पुश करेगा, एंड हार्ट विल टर्न अपवर्ड्स एंड आउटवर्ड्स, यानी कि लेफ्ट साइड की तरफ हार्ट टिल्ट हो जाएगा. जब हार्ट लेफ्ट साइड की तरफ टिल्ट होगा तो ईसीजी में भी हमें लेफ्ट एक्सिस डिविएशन मिलेगा. एंड जब हम एक्सरे करेंगे हमें ऐसा लगेगा, होगा नहीं, हमें ऐसा लगेगा दैट देयर इज माइल्ड अपैरेंट कार्डियोमेगली। अपैरेंट का मतलब हमें फील हो रहा है, कार्डियोमेगली है नहीं, लेकिन हमें फील होता है दैट एज इफ देयर इज माइल्ड अपैरेंट कार्डियोमेगली, राइट? नाउ व्हेन इट कम्स टू हार्ट डिजीज इन प्रेगनेंसी, heart disease with maximum maternal mortality. Which heart disease has maximum maternal mortality? Please remember it is Eisenmenger syndrome. Eisenmenger syndrome is an example of secondary pulmonary hypertension. What is the most common heart disease in pregnancy? Most common heart disease in pregnancy is mitral stenosis. What is the most common congenital heart disease in pregnancy? Most common congenital, CHD I'm saying, congenital heart disease. Most common congenital heart disease in pregnancy is ASD. Most common congenital valvular heart disease in pregnancy. Most common congenital valvular heart disease in pregnancy is mitral valve prolapse. Right? What is the most common cyanotic congenital heart disease in pregnancy? Most common cyanotic congenital heart disease in pregnancy. Which is the most common cyanotic congenital heart disease in pregnancy? Batao. Batao. Cyanotic congenital heart disease, TOF. Tetralogy of Fallot. Now, what is the preferred mode of delivery in heart disease patients? What is the preferred mode of delivery? Preferred mode of delivery is vaginal delivery. Vaginal delivery using forceps, which is better than vacuum. So vaginal delivery, jahan pe we are going to cut short the second stage of labor. We are going to cut short the second stage of labor using forceps ya vacuum. Then please remember, in heart disease patients, what is contraindicated? In heart disease patients, injection methyl ergometrin is contraindicated after delivery. Now, in heart disease patients, you have to restrict the fluid. You have to give them something for pain relief. Right? Are you going to do active management of third stage of labor? Yes. Are you going to give her oxytocin? Yes. Are you going to give her methergin? No. Clear to all of you? These are the important points which you have to remember in heart disease patients. Also, you have to remember there are heart diseases where pregnancy is contraindicated. What are those heart diseases where pregnancy is contraindicated? Whenever your patient has pulmonary hypertension, Eisenmenger's syndrome, right? Severe mitral stenosis, right? Severe mitral stenosis. Then in case of coarctation of aorta, right? Coarctation of aorta. Jitendra, most common congenital heart disease is ASD. अब तुमने पूछा है, and just let me check कि कहीं मैं confuse हो रही हूँ. Just let me check. I hope I am not getting confused. I should not be getting confused. ASD. I told you it's ASD. Most common congenital heart disease is ASD. right? Next, when is cardiac output maximum? अब ये question they can ask, when is cardiac output maximum? Or they can ask you, when are the chances of heart failure maximum? When are the chances of heart failure maximum? When are the chances of heart failure maximum? Chances of heart failure are maximum immediately after delivery. Immediately after delivery. अगर ये ऑप्शन में नहीं दिया है, then late second stage of labor. Then second stage of labor, immediately after delivery is the best answer. Second best answer is second stage of labor. Third best answer is late first stage of labor. And then it is 28 to 32 weeks of pregnancy. So when is cardiac output maximum, or when are the chances of heart failure maximum? Immediately after delivery, then second stage of labor, then late first stage of labor, and then 28 to 32 weeks of pregnancy. Now, when does cardiac output begin to increase in pregnancy? When does cardiac output begin to increase in pregnancy? It begins to increase in pregnancy by 6 weeks. After delivery, when does cardiac output become normal? So after delivery, cardiac output becomes normal within 10 days of delivery. Within 10 days of delivery. So when does cardiac output begin to increase in pregnancy? It begins to increase in pregnancy by 6 weeks. Pregnancy में वो maximum कब होगा? Pregnancy में maximum cardiac output होगा between 28 to 32 weeks of pregnancy. Then after delivery, cardiac output normal कब आ जाएगा? It will come back to normal within 10 days of delivery. Clear to all of you? Yes? Clear? So that is all what I wanted to revise with you today. Again, I will be taking a class tomorrow. Timing will be informed to you by Nitishji. Now you can ask whatever queries you have. 5 minutes I'm giving you. You want to ask any queries? I am there to take up your queries. Tell me any queries which you have, people? Any queries which you people have? Any queries? Anyone? No queries, beta? No questions? But you keep on practicing MCQs. That's very, very important. Right? Ma'am, uterine prolapse. Okay? I'll do uterine prolapse with you. Ma'am, all lectures. See, why I'm taking lecture on YouTube just now? Because I am taking my classes. Classes के साथ I'm just seeing कि कहाँ पे मुझे window मिल रही है. I am taking your 2 hours class, and these 2 hours class are on YouTube. जैसे ही I'm going to return to Delhi, I'm going to take 1 full day class, and that class will not be relayed on YouTube. Right? NST and CST, ठीक है. Parenteral iron की dosage, you don't need to know. Don't worry. Okay, beta. Okay. PDF, I will share entire PDF with all of you. I'll share the PDF with all of you. Right? Okay, take care all of you. Bye-bye.